I don't have any disclosures. I'm open for suggestions. All right, so we're going to go over a quick algorithm because, like Dr. Spencer said, this is not always about just vascular or just venous disease. So it's important to remember what the definition of edema is. Edema is whenever the capillary filtration rate at the level of the capillary bed exceeds that tissue drainage rate. And capillary filtration is dependent upon venous pressure, endothelial competency at the level of the capillary bed. It's related to oncotic and osmotic forces within the blood itself, and then it has to be supported by adequate venous return. So when we talk about venous pressure, there's really four components that help us control venous pressure. We have to have a normal central pump. We have those oncotic and osmotic forces at the level of the capillary bed. In order to support that column of blood going back to the heart, we have to have intact venous valves, and then we have to have a normal calf muscle pump to help pump that blood back up against gravity towards the right side of the heart. So when we look at what creates venous pressure at the level of the capillaries, anything that creates right ventricular pressure volume overload, anything that changes plasma volume, whether it's sodium and water retention or it's pharmacologic sodium retention, or if it's protein distribution, venous obstruction and venous reflux that increase venous pressure, or if you have an impaired calf muscle pump, so you can't pump that pressure like you need to. And then anything that increases capillary permeability, inflammation, trauma, but also vasodilation, and that's where we get into trouble with many of our medications. We have to remember and look for our low oncotic forces, low protein states, malnutrition, particularly in the elderly, is a very common cause. We don't want to miss our protein losses or anything, again, that changes our capillary permeability. So really, when we look at impaired venous return, this is a very complex process. Anything that increases central pressure, so even just central obesity increases that central abdominal pressure, will impair venous return. Obviously the right heart, but we have to remember pulmonary hypertension, underlying lung disease, COPD, and sleep apnea. Anything that changes our venous pressures, and then poor calf muscle pump. So we always have to look around the room, ask about immobility or mobility aids, things like ankle foot orthoses, if a patient's walking with a cane or a walker, or if you watch them walk in and they have an abnormal gait. That will impair your venous return and can lead to lower extremity swelling. On the other side is the ability to clear the tissue and the ability to clear what normal tissue fluid we make. So every day we're going to make about 6 liters of tissue fluid, and we have to have adequate lymphatic relief to clear that fluid. If we bring in 6 liters and we put out 6 liters, everything remains in balance. If we have a high input, so we have impaired or we have increased central venous pressures, or we have a protein or a fluid state that increases our tissue fluid, but we have normal lymphatics, we will still have lower extremity swelling because we haven't cleared that fluid. If we have normal input and everything is fine centrally, but our lymphatics are impaired and they don't clear, we again will have what we consider typical lymphedema, but we'll have lower extremity or have swelling. And then there are a number of mixed etiologies where we may have higher input and concomitant lower output, as in the case of phlebolymphedema, and we end up with a lot of lower extremity or edema swelling. So when I approach the patient, I kind of start at the foot of the bed. If it's symmetrical bilateral swelling, I'm thinking systemic or central etiologies. If it's bilateral but asymmetric, I think you have to be aware that you probably have a central or systemic etiology, but you may have, again, an associated lymphatic or venous component that is contributing to that asymmetry. If it's unilateral swelling, that is typically pathology related to one trunk, one limb, or one quadrant of the body. So when we evaluate these patients, we always start at the beginning. My differential changes if the patient is very young versus very old, if the distribution is upper extremity, lower extremity, or if it's unilateral or bilateral. History is very important. If it's acute versus chronic, your differential changes dramatically. Intermittent, persistent, or progressive, and of course you have to pay very strong attention to all of your comorbidities. You want to make sure there's no cardiac disease, no liver disease, renal disease, no malignancy, or any other interruption that may have happened in the pelvis and any other musculoskeletal issues. Always be aware of medications and drug exposures. Again, looking for your physical limitations. Ask about sleeping in a chair. About 30% of my patients with bilateral lower extremity swelling sleep in a chair. And then your physical exam is going to support all of those initial considerations. There's a whole list of medications that you need to be aware of, and almost any medication will list lower extremity or edema swelling as a side effect, but please be aware, and one of the biggest offenders are gabapentin and Lyrica, which a lot of patients seem to be on, at least in my practice. Once you've gone through all of your evaluation, you have to formulate your differential. And I put this up here not so that we can go through all of this, but the differential needs to pay attention to vascular etiologies, but don't forget about potential infectious, inflammatory, neoplastic, drugs, iatrogenic etiologies, developmental and inherited etiologies, anatomic issues, or trauma and environmental issues. And that is true for both bilateral and unilateral swelling, and the differential changes. So these lists are not the same, and they will be available to you on your app. So how do I look at this? From the foot of the table, when I see the patient, I look at their age. That gives me my upfront. If this is an 80-year-old lady with fairly acute lower extremity swelling, I'm worried about a pelvic neoplastic process, and I need to look there. If the distribution is bilateral, again, central or obstructive type processes, look at the onset. If it's acute, my differential is different than if this has been going on for a year or 2 years or 3 years. All of the associated clinical signs and symptoms are important. Initial evaluation should include at least what you have available to you, and you don't have to redo these if you have them available, but renal panel, metabolic panel, thyroid function, urine spot for protein, and an echocardiogram for patients with bilateral lower extremity swelling I think are important. You can use your vascular exam and your vascular lab to help you look at venous integrity as far as excluding DVT if it's an acute process, or looking for venous reflux and obstruction, and competency if it's more of a chronic or long-standing process. But I don't think this is always my first test or my first thought. And then appropriate imaging with CT, MRI, MRV, and lymphoscintigraphy if your differential leads you down those pathways. So, bottom line, start with your physical exam, your imaging, your laboratory, and your history to help you look at your underlying etiology. That thorough clinical assessment is going to help you tailor your differential. Keep your differential broad. It's not all about venous disease. Imaging is helpful for both the diagnosis as well as the exclusion of your differentials. And then identify your underlying etiology and treat that for your lower extremity swelling. And with that, I'll thank you for your attention.